Picture this. The alarm sounds, the lights flash, and you are thrust into a high-stakes world where a single wrong move can escalate chaos into absolute tragedy. Welcome to the invisible architecture of emergency response, where we break down the critical mechanics of crisis operations and human assessment. In this exploration, we are diving into the foundational laws of emergency medical services, dissecting how professionals guarantee survival, navigate high-stakes legal boundaries, and decode the human body under extreme stress. These core principles form the operational blueprint for every single high-pressure call encountered in the field. Mastering this framework transforms raw panic into absolute operational confidence, building the essential foundation required to navigate a career in emergency services. To begin truly testing your command over these intense real-world scenarios, utilizing specialized practice tests or an offline learning app serves as an excellent educational tool to guide your development from day one. The absolute first step when answering a crisis call begins the exact second a team is dispatched, long before anyone ever lays a hand on a patient. In the high-stakes world of emergency response, you must first evaluate the entire environment for hidden hazards, scanning for oncoming traffic, downed live power lines, or volatile, aggressive bystanders, to guarantee the ultimate safety of the response team. Professional medical frameworks heavily emphasize this tactical evaluation, frequently presenting scenarios where the natural instinct to rush in and treat a patient must be suppressed in favor of establishing total scene safety. During this high-stakes initial phase, responders must also rapidly deduce the mechanism of physical injury or the true nature of an illness, accurately count the total number of casualties, and immediately request additional specialized resources if the situation demands it. Closely tied to managing the environment is the concept of erecting a biological barrier between yourself and the crisis, known in the medical world as body substance isolation, and the strategic deployment of personal protective equipment. In the field, professionals must operate under the universal assumption that all biological fluids are potentially hazardous, a foundational defensive strategy known as standard precautions. In real-world crisis management, donning protective gloves and safety eyewear is universally mandated as the absolute first action required before making any patient contact. Wearing the correct protective gear shields responders from invisible, communicable pathogens, ensuring that the people arriving to solve the emergency remain healthy enough to keep helping others throughout their careers. Navigating the human element of a crisis requires an intricate understanding of medical law, starting with the complex principle of consent, which governs the legal right to provide human care. Expressed consent occurs in the real world when a conscious, mentally competent adult clearly communicates their permission, either verbally or through a nonverbal nod, to receive treatment. Implied consent, by contrast, activates during a true worst-case scenario where a patient is completely unconscious, confused, or catastrophically injured, allowing the law to logically assume they would want life-saving intervention if they were physically able to ask for it. Emergency frameworks frequently test the exact boundaries of this implied permission, particularly in high-stress cases involving severe drug overdoses or major head trauma where a patient's mental faculties are completely altered. Yet a conscious and competent adult always retains the absolute legal right to refuse medical intervention, even when that exact choice will result in their ultimate demise. To legally accept a patient's refusal of life-saving care, an emergency responder must verify that the individual is completely oriented to person, place, time, and the event taking place, while remaining entirely free from the altering effects of drugs or alcohol. The responder is legally required to explicitly detail the dire consequences of refusing care, up to and including death, and document this intense conversation meticulously within the official medical record. Forcing medical treatment upon a stubborn but legally competent adult against their conscious will crosses a definitive legal boundary and is classified as battery. When an emergency professional fails to uphold the established standard of care and causes direct harm to a patient, they enter the dangerous legal territory of negligence. Proving negligence in a high-stakes environment requires 4 specific criteria to be flawlessly established: a definitive duty to act, a clear breach of that specific duty, actual physical or emotional damages inflicted on the patient, and proximate cause, meaning the responder's specific mistake directly triggered the harm. It is highly common for people to confuse a simple, honest mistake with legal negligence, but the law strictly dictates that all four elements must be present to establish liability. Understanding this legal shield protects professionals from devastating liability, while ensuring they always act in the absolute best interest of the human being in front of them. And utilizing targeted practice tests or an offline app can be incredibly helpful for mastering how these legal boundaries are framed. Patient privacy in a crisis is fiercely guarded by a powerful federal mandate known as the Health Insurance Portability and Accountability Act, or HIPAA. This strict law dictates that you are legally forbidden from sharing any protected medical information with anyone who is not directly involved in the immediate, ongoing care of that specific patient. For instance, while it is perfectly legal to transfer a patient's medical history to the receiving triage nurse at a hospital, discussing those exact same intimate details with friends or posting about the intense call on social media is a severe federal violation. True professionals must instantly recognize the line between legal medical handoffs and serious privacy violations, constantly guarding patient confidentiality like a fortress. Beyond the legalities, emergency response is an intensely physical discipline, requiring precise biomechanical lifting and moving techniques to prevent career-ending spinal injuries. Responders must consciously engage their powerful leg muscles, maintain a perfectly straight spine, and hold the massive weight of a patient as close to their own center of gravity as possible, while utilizing a highly secure power grip. True emergency moves are strictly reserved for environments that pose an immediate, lethal threat to life, such as an active vehicle fire, whereas urgent moves are deployed when a patient possesses a catastrophic internal condition requiring rapid extrication. Professional frameworks require responders to instantly differentiate between these movement styles based entirely on the volatile safety of the environment and the critical status of the patient. Clear, concise communication serves as the ultimate tactical lifeline during a crisis, seamlessly connecting field responders with dispatch centers, medical directors, and emergency departments. When delivering a high-pressure radio report, a professional must be incredibly brief, highly accurate, and completely objective, painting a vivid clinical picture of the patient's current status without ever revealing their name or breaching federal privacy laws. Responders are trained to use standardized medical terminology while entirely banning informal slang or unapproved shorthand to guarantee flawless understanding between different public safety agencies. Mastering this clear communication loop ensures that an entire hospital trauma bay is fully prepared and waiting the exact second a critical stroke or accident victim arrives at the doors. The true art of managing a medical crisis relies on a highly structured patient assessment sequence, beginning with the primary assessment, which is designed to instantly isolate and neutralize immediate threats to life. The very moment a professional approaches a patient, they form a rapid general impression, instantly analyzing age, sex, level of visible distress, and overall physical posture before a single word is spoken. This lightning-fast visual scan dictates the entire tempo of the rescue, determining within seconds whether a patient is classified as structurally stable or critically ill. Missing a hidden life threat during this opening phase completely derails the rescue, which is why professional frameworks place immense weight on mastering the general impression. Immediately following that initial visual scan, a responder must rapidly gauge the patient's neurological status using a streamlined metric known as the AVPU scale. This vital acronym categorizes human responsiveness into 4 distinct levels: alert, verbal, painful, and unresponsive, allowing for an instant categorization of a patient's mental clarity. An alert individual will naturally track movements with their eyes, whereas a patient responding only to pain might emit a low groan only when physical pressure is applied to their sternum. A dropping score on this scale serves as a massive red flag, signaling rapid neurological decline, and it is a concept frequently used to indicate a fast-worsening medical emergency. Once the level of consciousness is established, the focus shifts entirely to the ultimate physiological priorities: securing the airway and managing breathing. If a patient is speaking clearly, their airway is naturally open, but if they are unresponsive, a responder must immediately intervene to manually open the passage, using a precise head tilt chin lift or a tactical jaw thrust maneuver. The responder then carefully measures the rate, rhythm, and overall quality of the breath, intervening instantly with supplemental oxygen or positive pressure ventilation if the respiration drops too slow, becomes too shallow, or stops entirely. Every established medical protocol demands that these critical airway and breathing crises be completely resolved before any other physical evaluations can continue. With the breath secured, the focus shifts to evaluating the circulatory system by analyzing the pulse, checking the skin, and halting any catastrophic blood loss. For a conscious adult, a responder will quickly check the radial pulse at the wrist, but if the patient is unresponsive, they must immediately check the powerful carotid artery in the neck to verify if the heart is still effectively pumping blood. Simultaneously, evaluating the skin's color, temperature, and moisture level provides an instant window into systemic shock, which presents as pale, cool, and clammy skin. If massive arterial bleeding is discovered, the traditional protocol order is instantly broken. Stopping a catastrophic hemorrhage via a tourniquet is the single exception that overrides the standard airway and breathing sequence. The final decisive step of this initial assessment phase is making a critical transport decision, which instantly prioritizes the patient for rapid evacuation. High priority status is reserved for individuals experiencing agonizing pain, altered mental states, severe respiratory distress, or highly unstable vital signs, mandating immediate transport to the nearest specialized trauma center or hospital. Low-priority patients, by contrast, are fundamentally stable, allowing responders to conduct a deeper, more relaxed evaluation right on the scene before beginning the drive to the hospital. Triage systems heavily test a responder's ability to look at a chaotic multi-patient scene and accurately identify exactly who requires immediate, rapid transport. Once the immediate life threats are controlled, responders transition into history-taking, utilizing a powerful clinical mnemonic known as SAMPLE to uncover the patient's medical past. This acronym systematically extracts critical data: signs and symptoms, allergies, medications, past medical history, last oral intake, and the precise events leading up to the crisis. Gathering this data provides a comprehensive snapshot of the patient's background, which frequently uncovers the exact root cause of the current emergency. For example, discovering that a confused patient took their morning dose of insulin but completely missed eating lunch perfectly explains a sudden altered mental state, a vital piece of deductive reasoning required in real-world medicine. When a patient is experiencing a highly specific, intense symptom, like crushing chest pain or severe shortness of breath, responders deploy a second diagnostic tool called OPQRST. This advanced mnemonic analyzes the symptom through 6 distinct lenses: onset, provocation, quality, radiation, severity, and time, allowing the responder to characterize the exact nature of the suffering. Asking whether a sharp chest pain radiates outward to the jaw or down the left arm helps a responder instantly identify a potential heart attack, while pinpointing the exact time the symptoms started dictates time-sensitive hospital interventions. Mastering this deep diagnostic communication allows field professionals to paint a flawless clinical picture for the receiving emergency room physician. The secondary assessment steps away from immediate life threats to conduct a meticulous, head-to-toe physical examination designed to uncover hidden injuries or developing medical conditions. For a victim of physical trauma, this involves carefully palpating the head, neck, chest, abdomen, pelvis, and extremities, searching for deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. For a purely medical patient, this physical exam is highly focused, targeting only the specific biological system related to their primary complaint. Responders must know exactly when to execute a rapid, full-body trauma sweep versus a highly focused medical examination based entirely on the physical forces involved in the accident. To back up these physical findings with hard data, obtaining a baseline set of vital signs provides objective metrics regarding the body's internal stability. A complete, professional physiological profile requires measuring blood pressure, heart rate, respiratory rate, oxygen saturation, and blood glucose levels. True expertise lies not just in obtaining these numbers under chaotic conditions, but in instantly recognizing abnormal variances across different age demographics. Comparing this initial baseline data against subsequent measurements taken over time allows responders to track vital trends, showing definitively whether a patient is stabilizing or critically deteriorating under their care. The final phase of this intense life cycle of care is the reassessment, a continuous, vigilant process executed while the ambulance is actively en route to the hospital. During this mobile phase, the responder systematically repeats the primary assessment, rechecks the vital signs, critically evaluates the effectiveness of their medical interventions, and monitors the patient for any sudden physiological shifts. A stable patient requires a fresh reassessment every 15 minutes, whereas a highly volatile, unstable patient demands a full reassessment every 5 minutes without exception. Maintaining this strict timing rule ensures absolute vigilance, guaranteeing that a patient is never left unmonitored during the critical transit window. Understanding how these high-stakes systems work is only the beginning of mastering emergency medicine and crisis operations. If you want to take this foundational knowledge further, protect human lives in the real world, and prepare professionally for the field, you can use the free study guide and practice resources linked in the description to start your certification journey. Actively challenging yourself with realistic, high-pressure scenarios is the ultimate way to improve your clinical retention and ensure absolute exam readiness. Don't forget to check the description to get your free study guide and additional resources to help you prepare. And I look forward to guiding you through our next deep dive, where we will conquer the critical, life-saving world of advanced airway management and respiration. Imagine having the literal power to breathe for a human being who has entirely lost the ability to do it for themselves. Welcome to the invisible, high-stakes mechanics of human respiration and airway management, where we explore the biological systems that keep us alive and the incredible interventions used when those systems catastrophically fail. In this deep dive, we will unpack the hidden anatomy of the human respiratory system, decode the subtle physical signs of a body starving for oxygen, and examine the precise mechanical devices designed to force life back into failing lungs. Mastering this knowledge is incredibly vital, as securing a compromised airway is universally recognized as the absolute most critical, life-saving intervention a professional responder can execute in the field. As we explore the ultimate foundation of pre-hospital emergency survival, testing your grasp on these intense concepts with specialized practice tests or an offline learning app serves as an excellent tool to gauge your true readiness from the very start. To truly understand how we secure human life, we must first examine the intricate architecture of the upper airway, a biological funnel comprising the nose, mouth, pharynx, and the highly critical larynx. This upper corridor acts as the body's natural climate control system, meticulously warming, filtering, and humidifying raw environmental air before it ever reaches the delicate tissues deeper inside the chest. In professional medical frameworks, a vital anatomical landmark to remember is the larynx, commonly known as the voice box, which acts as the definitive border dividing the upper and lower respiratory tracts. This checkpoint is so vital that any sudden swelling or physical blockage occurring just above this line, whether from a severe allergic reaction or a lodged piece of food, instantly threatens a person's entire ability to survive. Journeying deeper past the voice box, the architecture transitions into the lower airway, a branching network that includes the rigid trachea, the sprawling bronchi, the microscopic bronchioles, and finally, the alveoli. These alveoli are essentially millions of microscopic, balloon-like air sacs resting at the absolute end of the respiratory line, serving as the biological stage where the actual magic of gas exchange occurs. Every time a person takes a breath in, vital oxygen travels down into these fragile sacs and seamlessly crosses into the human bloodstream, while toxic carbon dioxide is pushed from the blood back into the sacs to be forcefully exhaled. Understanding this microscopic transaction is critical for survival experts, because any fluid buildup or physical damage inside these tiny alveoli will instantly block oxygen from reaching the brain, triggering rapid and catastrophic physical deterioration. When analyzing how the body processes air, many people naturally confuse the concepts of ventilation and respiration, yet in the precise medical world, these two terms describe entirely distinct life functions. Ventilation is strictly the mechanical, physical action of moving raw air in and out of the chest cavity, functioning exactly like a mechanical bellows pumping wind into a roaring fire. Respiration, on the other hand, describes the invisible chemical exchange of those gases, happening either inside the lungs themselves or down at the microscopic cellular level throughout the entire human body. A responder can mechanically ventilate a victim's lungs flawlessly, but if that person is suffering from something like severe carbon monoxide poisoning, which fundamentally blocks chemical respiration at the cellular level, they will tragically still suffer from internal oxygen starvation. Before anyone can attempt to fix a catastrophic breathing emergency, they must possess the ability to instantly recognize what a normal, perfectly healthy respiratory baseline actually looks like. A structurally stable adult at rest will reliably pull in exactly 12 to 20 breaths every single minute, maintaining a beautifully regular rhythm and a relaxed, effortless depth to every single inhalation. When a professional presses a stethoscope to a healthy chest, the internal acoustics of the rushing air should sound perfectly clear and identically equal on both sides of the ribcage. If a human being naturally meets all of these physiological criteria, their ventilation system is functioning adequately without the need for aggressive mechanical interventions, though they might occasionally still benefit from a gentle flow of supplemental oxygen. The moment the body struggles to pull in enough air, it aggressively shifts into a state known as respiratory distress, a desperate biological fight that must be identified early before the victim completely exhausts their energy reserves. The physical warning signs of this distress are highly visible, presenting as a dangerously fast or slow breathing rate, the intense flexing of accessory muscles in the neck to manually heave the chest open, and the frantic flaring of the nostrils. Observers will frequently see a suffocating individual instinctively lock themselves into a seated, forward-leaning tripod position, bracing their hands heavily against their own knees in a desperate attempt to maximize their lung expansion. Emergency professionals are rigorously trained to spot these early, frantic warning signals and immediately intervene with high-flow supplemental oxygen to reduce the body's mechanical workload, a crucial visual identification skill that is heavily reinforced through realistic practice tests and offline study apps. If that frantic distress is tragically ignored, or if the sheer physical effort of fighting for air simply burns out the patient's muscles, the body plummets into the lethal territory of respiratory failure. This total biological collapse is a massive, life-threatening emergency, marked by a rapidly deteriorating mental state, shockingly shallow chest movements, and a sudden, terrifying drop in the overall breathing rate. At this precipice, the body's extreme oxygen starvation forces the skin to take on a horrific, bluish tint, a severe late-stage symptom clinically known as cyanosis. If an individual is found breathing a mere 6 times a minute while becoming impossible to physically wake up, professional protocols demand instantly recognizing this catastrophic failure and immediately taking over their breathing through artificial mechanical ventilation. When confronting a completely unconscious human being, the absolute first physical intervention is to manually pry open their collapsed airway, physically lifting the dead weight of their own tongue away from the back of their throat. If the individual is suffering from a purely medical event with absolutely no suspicion of physical trauma, responders deploy the standard head tilt chin lift maneuver to lever the skull backward and open the biological pipe. However, if there is even a slight suspicion of a violently fractured neck or damaged spinal cord, such as after a brutal car crash or a massive fall, responders are absolutely forbidden from tilting the head and must instead utilize the specialized jaw thrust maneuver. Protecting the fragile cervical spine by defaulting to the jaw thrust during severe trauma is a foundational rule of emergency medicine that is constantly tested and strictly enforced in the field. Once that vital airway is manually pried open, professionals often deploy specialized plastic hardware to ensure the heavy tongue stays pinned out of the way, beginning with the oropharyngeal airway, or OPA. This rigid, brilliantly curved piece of plastic is driven directly into the mouth, but it carries a massive restriction. It can only ever be utilized on a completely unconscious human being who has entirely lost their biological gag reflex. To ensure a perfect anatomical fit, the device must be precisely measured against the side of the patient's face, spanning the exact distance from the corner of their mouth to the tip of their earlobe. If a responder attempts to insert this rigid plastic and the patient violently gags, the absolute rule is to rip the device out instantly, as leaving it in will trigger catastrophic vomiting and lethal choking. For individuals who stubbornly retain an intact gag reflex or remain semi-conscious during the crisis, responders switch to a different tool called a nasopharyngeal airway, universally referred to as an NPA. This alternative is a highly flexible, soft rubber tube designed to be fed directly through the nasal cavity, requiring an exact measurement from the tip of the patient's nose back to their earlobe. Before insertion, this rubber tube must be heavily lubricated and then slowly, gently threaded down the right nostril, ensuring the angled bevel perfectly faces the inner septum. However, a terrifying medical rule dictates that an NPA must never be used if severe head trauma or a basilar skull fracture is suspected, because the incredibly soft tubing could accidentally be forced upward through the broken bone directly into the patient's brain cavity. In chaotic real-world scenarios, a patient's breathing passage is frequently blocked by thick biological debris, like vomit, heavy blood, or dense secretions, requiring the immediate deployment of a powerful mechanical suction unit. Responders rely on a rigid plastic wand, professionally termed a Yankauer catheter, to aggressively vacuum out the inner mouth and the deep back of the throat. The absolute golden rule of this procedure is to strictly apply the vacuum force only while actively pulling the wand completely out of the mouth, sweeping it aggressively from side to side. Furthermore, professionals are strictly forbidden from vacuuming an adult's airway for more than 15 agonizing seconds at a single time, because the powerful machine rapidly steals the victim's remaining vital oxygen alongside the fluid. When it comes to artificially supplementing a patient's breathing, responders haul high-pressure oxygen cylinders into the field, handling these immense steel vessels with an extreme level of caution. Because the gas inside is compressed to a highly explosive degree, responders must attach a heavy-duty regulator to safely drop the extreme internal pressure down to a biologically usable flow before it ever hits the patient's lungs. These vital tanks must be completely swapped out the second their internal pressure gauge drops down to 200 pounds per square inch, which is universally classified as the absolute lowest safe residual pressure. More importantly, these heavy cylinders must always remain heavily secured and laying perfectly flat when not in use, as a suddenly snapped valve instantly transforms the heavy metal tank into an unguided, high-speed missile. For a human being who is experiencing only mild respiratory difficulty, or who simply requires a gentle biological boost, the nasal cannula serves as the most elegant and common delivery tool. This simple, lightweight plastic tubing features two tiny prongs that rest just inside the nostrils, delivering a very low, steady flow of pure oxygen, set anywhere between 1 and 6 liters per minute. Pushing gas at this specific rate smoothly bathes the patient in an oxygen concentration ranging from roughly 24 to 44%, which is typically the exact perfect amount for a medically stable individual. The discreet nasal cannula also serves as an absolute lifesaver for frantic patients who suffer from severe claustrophobia and aggressively refuse to tolerate a tight, suffocating mask strapped across their face. Conversely, when a human being plunges into absolute respiratory terror, massive biological shock, or severe physical trauma, they require a massive blast of oxygen delivered via a heavy-duty non-rebreather mask. This aggressive device tightly seals over both the nose and mouth and features a dangling plastic reservoir bag, allowing it to blast the victim with up to 90% pure oxygen when paired with a massive flow rate. To operate it safely, the regulator must be cranked completely open to a roaring 10 to 15 liters per minute, and the responder must guarantee the attached reservoir bag is fully inflated before the plastic is ever strapped onto the patient's face. In highly critical scenarios, this specific, heavy-duty mask is the absolute gold standard for any severely short of breath, catastrophically injured, or wildly unstable human being. When a person's biological systems entirely fail and they completely stop breathing on their own, a terrifying clinical state known as apnea, passive oxygen masks become entirely useless, forcing the responder to manually breathe for them. This aggressive mechanical takeover is called artificial ventilation, and the ultimate weapon for this job is the iconic bag valve mask, universally known as the BVM. To keep an adult human alive with this device, the responder must physically crush the bag exactly once every 5 to 6 seconds, forcing just enough air down the pipe to make the victim's chest visibly lift. The absolute ultimate proof that this desperate mechanical intervention is actually working is constantly verifying that each squeeze results in an adequate, entirely equal rise and fall of the patient's chest. Attempting to operate this life-saving bag completely alone is notoriously difficult, primarily because maintaining an absolutely flawless, airtight seal against the face while simultaneously crushing the bag requires extreme physical dexterity. Because of this massive difficulty, deploying two entirely separate rescuers to operate a single bag valve mask is universally heavily preferred and strongly mandated by top national medical guidelines. In this choreographed dance, one responder uses both of their hands to crush the mask tightly against the facial bones, using the highly effective EC clamp technique, leaving the second responder totally free to smoothly squeeze the bag with both hands. The EC clamp technique is a brilliant anatomical maneuver where the thumbs and index fingers hook into a firm C shape atop the plastic, while the remaining 3 fingers curl into an E shape beneath the jawbone to pry the airway aggressively open. A highly dangerous and horrifyingly common complication of forcing air into a human being is triggering gastric distension, a massive error where the air is accidentally pumped deep into the stomach rather than the lungs. This terrifying physical expansion occurs entirely because the responder is violently squeezing the bag far too fast, using way too much physical force, or simply failing to position the airway at the correct anatomical angle. As the human stomach rapidly inflates like a balloon, it pushes upward against the diaphragm, physically crushing the lungs from below and skyrocketing the chances that the victim will violently vomit inside the mask. To completely prevent this dangerous internal pressure, responders must perfectly tilt the head backward and squeeze the bag with incredible gentleness, stopping the exact millisecond the chest barely begins to rise. An even more advanced mechanical weapon in this arsenal is continuous positive airway pressure, universally known as CPAP, which is heavily deployed to combat severe lung flooding seen in intense asthma, pulmonary edema, or chronic obstructive pulmonary disease. This aggressive machine utilizes a brutally tight mask to blast a ceaseless, high-pressure hurricane of air down the throat, manually forcing the microscopic alveoli to stay open while literally pushing drowning fluid backward out of the lungs. The single greatest rule attached to this powerful machine is that the human wearing it must remain completely conscious, highly alert, and entirely capable of maintaining their own biological breath. The very second a patient wearing a CPAP mask becomes too exhausted to fight or begins losing their mental clarity, the suffocating mask must be violently ripped off and immediately replaced with a manual bag valve mask. As you study the mechanics of human survival, it is terrifyingly vital to realize that pediatric airways are absolutely not just miniature replicas of adult anatomy. They possess highly unique biological differences that completely rewrite the rules of rescue. Small children possess disproportionately massive tongues that easily flop backward to block their own throats. Their windpipes are structurally soft and will completely collapse if a responder tilts their head back too aggressively, and they rely almost entirely on their tiny diaphragms to breathe. When attempting to open the delicate airway of an infant, a responder must slide a tiny rolled towel directly beneath their small shoulders, keeping their massive head in a perfectly neutral alignment to prevent the soft biological pipe from permanently kinking. Understanding how to seamlessly adapt aggressive adult techniques to ensure the ultimate safety of these incredibly fragile, tiny patients is a hallmark of true emergency mastery. Gaining a total, unshakable command over how the human respiratory system functions, fails, and can be artificially rescued is the ultimate cornerstone of keeping people alive in the most extreme conditions imaginable. Exploring the invisible mechanics of the airway and mastering the incredible tools used to manipulate human ventilation gives you the profound ability to change the outcome of someone's worst possible day. Understanding how these life-saving respiratory interventions work in the real world is only the beginning. If you want to take your knowledge further and prepare professionally to master these exact concepts for your certification, you can use the targeted practice questions and educational app included with this course to start your journey. Don't forget to check the description to get your free study guide and additional resources to help you prepare. Imagine a scenario where every single second ticking by dictates the literal difference between life and irreversible death. Welcome to the high-stakes world of emergency cardiology and resuscitation, where we are going to explore the invisible mechanics of the human cardiovascular system, how to spot the hidden signs of acute coronary syndrome, and the aggressive protocols used to battle sudden cardiac arrest. This exploration is incredibly vital because heart-related emergencies are some of the most time-critical events a human being can experience, and understanding how to intervene gives professionals the ultimate power to cheat death. Mastering these high-stress concepts transforms panic into absolute operational confidence when an entire life hangs in the balance. We are diving deep into the absolute heart of crisis response, and to lock in these foundational mechanics early, utilizing targeted practice tests or a specialized offline learning app serves as an incredible educational tool to test your true readiness from day one. To truly understand how these critical emergencies unfold, we first have to break down the biological architecture of the human heart, a relentless muscular organ tasked entirely with pumping vital blood throughout the entire body. This incredible biological machine is strictly divided into 4 distinct chambers, featuring the 2 atria at the very top and the 2 powerful ventricles anchoring the bottom. The right side of this system operates by pumping oxygen-depleted blood directly into the lungs to be refilled, while the massive left side violently pumps that freshly oxygenated blood out to feed the rest of the human body. You can perfectly visualize this organ as a highly tuned, high-performance engine, one that relies entirely on an uninterrupted supply of chemical fuel and internal electricity to keep the body running flawlessly. However, there is a fascinating mechanical flaw in this system. The thick heart muscle itself, scientifically known as the myocardium, is completely incapable of extracting oxygen from the vast oceans of blood pooling inside its own internal chambers. Instead, the heart is forced to rely on an entirely separate, external network of specialized plumbing known as the coronary arteries, which tightly wrap around the outside of the organ like a biological cage. These tiny, fragile arteries are responsible for delivering oxygen-dense blood directly into the heart's own muscle cells, ensuring the biological pump possesses enough raw energy to beat without stopping. A highly critical concept to grasp in any medical framework is that a sudden physical blockage inside these specific outer arteries instantly starves the actual heart muscle of its vital oxygen, directly triggering a catastrophic cardiac emergency. When one of these vital coronary tubes becomes even partially blocked, usually by a silent, slow buildup of thick fatty plaque, the struggling heart muscle immediately experiences a terrifying lack of oxygen, known clinically as ischemia. This sudden biological starvation forces the body to project a highly specific type of crushing chest pain, known as angina pectoris, a warning alarm that typically triggers during intense physical exertion or massive emotional stress. Fortunately, this specific pain usually completely resolves the moment the patient aggressively rests or takes a prescribed dose of nitroglycerin medication. leaving absolutely no permanent structural damage to the actual heart muscle. Within certification examinations, a scenario describing severe chest pain that entirely vanishes the moment a patient rests serves as the absolute classic, textbook presentation of stable angina. But if that fragile coronary artery becomes 100% blocked by a sudden, massive blood clot, the actual cells of the heart muscle will begin to permanently die within mere minutes, triggering a catastrophic acute myocardial infarction, which is the official medical classification for a massive heart attack. Unlike the temporary warning signs of angina, the terrifying pain generated by a true heart attack absolutely will not fade away with rest, and the rapid death of the cardiac tissue is completely irreversible. Victims frequently describe this intense suffering as a crushing, suffocating heaviness, famously comparing it to an elephant sitting directly on their chest, with agonizing pain that rapidly radiates outward into the left arm, up into the jaw, or deep into the back. Emergency professionals must instantly recognize these terrifying physical signs, because saving the dying heart muscle relies entirely on executing a rapid, high-speed transport to a highly specialized surgical hospital, capable of physically clearing the blocked plumbing. Because it is physically impossible to definitively distinguish between a severe angina attack and a completely lethal heart attack out on the street, without advanced imaging equipment, crisis professionals utilize a brilliant umbrella classification known as acute coronary syndrome. This broad operational term is applied to any cluster of physical symptoms caused by cardiac oxygen starvation, strictly prompting responders to treat every single chest pain patient with the exact same extreme level of medical caution. The ultimate operational goal in the field is simply to recognize the deadly potential for a heart attack, immediately provide aggressive, supportive care, and initiate rapid transport without wasting precious time guessing the diagnosis. Medical certification tests will frequently utilize this exact umbrella term, strictly testing a professional's ability to always assume the absolute worst-case scenario is happening and execute treatments accordingly. A massive biological trap that frequently catches people off guard is the shocking reality that not every single human being actually experiences that classic, movie-style crushing chest pain while their heart is actively dying. Women, the elderly, and individuals living with diabetes notoriously present with what experts call atypical symptoms, meaning their physical warning signs of a massive heart attack are incredibly unusual or dangerously subtle. Instead of clutching their chest in agony, these highly vulnerable populations might simply complain of a sudden, overwhelming weakness, unexplained bouts of nausea, severe indigestion, or just a strange shortness of breath that lacks any clear cause. Responders are strictly trained to maintain an incredibly high index of clinical suspicion for acute coronary syndrome the exact second they encounter a geriatric or diabetic patient who suddenly feels unwell, and utilizing practice tests or an offline study app can serve as a highly effective way to master how these tricky, atypical presentations are formatted. When battling this invisible clock, one of the most powerful chemical weapons a field professional can deploy for acute coronary syndrome is actually something completely ordinary: standard aspirin. Surprisingly, this common pill does not relieve the patient's immense pain, nor does it possess the ability to dissolve the massive blood clot currently destroying the artery, but it absolutely prevents that lethal clot from growing any larger. It achieves this by chemically altering tiny blood cells known as platelets, rendering them completely non-sticky and actively stopping them from clumping together at the site of the massive arterial roadblock. For professional competency, it is mandatory to remember that the strict standard field dose is up to 324 milligrams of easily chewable baby aspirin, but a responder must rigorously verify that the patient has absolutely no allergies or history of severe internal bleeding before ever handing it over. A second crucial chemical intervention you might witness during a massive cardiac crisis is a drug called nitroglycerin, provided it has been explicitly prescribed to the suffering patient by their own doctor. This intense medication acts as a powerful vasodilator, meaning it rapidly forces the body's blood vessels to physically relax and widen out, which instantly decreases the immense mechanical workload on the struggling heart and allows vital blood to slip past partial arterial blockages. It is rapidly administered as a tiny tablet or a chemical spray placed directly beneath the patient's tongue, a specific anatomical zone that allows the drug to immediately absorb straight into the central bloodstream. However, because this drug violently dilates the human plumbing system, nitroglycerin can trigger a massive and highly dangerous drop in overall blood pressure, strictly mandating that professionals check a complete set of vital signs before it is ever administered. Because human biology is incredibly fragile, professional frameworks fiercely test the absolute strict contraindications for nitroglycerin, specific conditions where giving this exact medication could directly harm or even instantly kill the patient. A responder is absolutely forbidden from administering this powerful drug if the patient possesses a systolic blood pressure reading below 100, or if they have recently suffered a severe physical head injury. The single most critical, heavily emphasized safety check is demanding to know if the patient has consumed any erectile dysfunction medications, such as Viagra or Cialis, within the preceding 48 hours. Stacking nitroglycerin on top of those highly specific drugs triggers an absolutely fatal, irreversible collapse in human blood pressure, making this highly uncomfortable inquiry an absolutely mandatory, life-saving question on every single cardiac response. Another catastrophic breakdown of this biological pump is known as congestive heart failure, a horrifying mechanical state that occurs when the heart entirely loses its raw physical ability to pump effectively, causing heavy bodily fluids to dangerously back up like a clogged drain. If the right side of this muscular engine fails, dense fluid physically backs up into the lower body, triggering massive swelling inside the legs, ankles, and deep abdomen, in a condition known as pedal edema. Conversely, if the massive left side of the heart fails, that heavy fluid violently backs up directly into the fragile lungs, creating a completely lethal, suffocating condition called pulmonary edema. Scenarios featuring a terrified patient who suddenly wakes up in the dead of night, violently gasping for air, violently coughing up pink frothy sputum, and exhibiting wet, crackling lung sounds, are massive, undeniable red flags pointing directly to lethal left-sided heart failure. Despite flawless medical intervention and massive effort, some dying hearts will inevitably deteriorate into full cardiac arrest, the terrifying ultimate absolute limit where the organ completely stops pumping blood altogether. The exact millisecond this occurs, the human brain instantly shuts down, causing the victim to immediately lose consciousness, completely stop pulling in oxygen, and instantly lose their physical pulse, an event that triggers a massive, undeniable adrenaline rush for any responder in the room. This exact precipice is the moment where executing high-performance CPR becomes the absolute sole focus of survival, as the responder literally transforms their own physical body into a manual, mechanical pump designed to force oxygenated blood upward into the dying brain. In these chaotic scenarios, time instantly becomes the ultimate, absolute enemy, because irreversible structural brain damage physically begins within a terrifying 4 to 6 short minutes of the biological pump stopping. Executing this artificial survival technique is not just frantic pushing. High-performance CPR requires extreme, calculated precision, focusing entirely on hitting the correct physical depth, maintaining the perfect tempo, and ruthlessly minimizing any interruptions during chest compressions. To keep an adult human alive, a responder must violently compress the direct center of the sternum down at least 2 full inches deep, maintaining a brutal, relentless speed of 100 to 120 compressions every single minute. Crucially, the responder must also allow the crushed chest wall to fully snap back and recoil after every single downward strike, a mechanical action that creates a powerful biological vacuum capable of pulling fresh blood back into the empty heart chambers. Professional exams will rigorously evaluate your precise knowledge of these exact, unforgiving metrics, because delivering absolutely flawless manual compressions is scientifically proven to be the single greatest determining factor in a human being surviving this event. While those brutal compressions physically circulate the stagnant blood, a responder must simultaneously provide artificial ventilations to guarantee that the moving blood is actually carrying life-saving oxygen. During standard adult CPR on a patient with a completely unprotected biological airway, the strict universal ratio demands exactly 30 manual compressions, followed instantly by exactly 2 forced breaths, utilizing a specialized bag valve mask. An incredibly common and highly lethal mistake people make under extreme stress is violently squeezing that bag with way too much physical force, forgetting that they only need to push enough air to make the victim's chest visibly lift. Aggressively overventilating a dying patient actively skyrockets the internal air pressure inside their chest cavity, a devastating error that physically crushes the fragile blood vessels, completely prevents blood from returning to the heart, and instantly destroys the entire mechanical effectiveness of those grueling chest compressions. Beyond manual pumping, the introduction of the automated external defibrillator, universally known as the AED, acts as a miraculous piece of technology specifically engineered to cure highly lethal, chaotic heart rhythms mid-crisis. A massive misconception surrounding this device is how it actually operates. An AED absolutely does not restart a completely dead, flatlining heart, an irreversible state medically defined as asystole. Instead, its internal computer hunts strictly for highly chaotic, completely disorganized electrical storms inside the chest, scientifically identified as ventricular fibrillation or ventricular tachycardia, and subsequently delivers a massive blast of raw electricity to violently stun the dying muscle. This intense electrical shock is designed to forcefully stop all biological electrical activity for a split second, desperately hoping that the heart's natural internal pacemaker will reboot, reset, and finally begin beating normally once again. The exact second this technological weapon arrives at a cardiac arrest scene, it must be powered on instantly, and the responder must flawlessly obey its robotic voice prompts without ever delaying their physical chest compressions. The operator violently rips open the patient's shirt to apply the sticky chemical pads directly to bare human skin, locking one pad high on the upper right chest and slamming the second pad tightly on the lower left rib cage. The absolute most critical safety rule attached to this high-voltage machine is guaranteeing that absolutely no human being is physically touching the patient's body while the computer analyzes the rhythm or detonates the electrical shock. The operator is strictly mandated to loudly declare that everyone must stand entirely clear, forcing them to visually confirm that their partners are safely backed away before ever pushing that glowing shock button. Operating this high-voltage equipment also demands that a responder be highly prepared to instantly adapt their application techniques for highly dangerous, special environmental variables found in the real world. If a victim happens to have a prescribed medication patch glued to their chest, the operator must violently rip it off with a gloved hand and rapidly wipe the toxic chemicals away before slapping the electrical pad down. If the dying patient possesses a completely soaked chest from a recent drowning or massive sweat, the skin must be aggressively dried off, so the massive blast of electricity punches directly downward through the heart, rather than uselessly skipping across the wet surface of the skin. Furthermore, if a responder spots a visibly bulging, surgically implanted pacemaker under the victim's collarbone, they are strictly trained to place the sticky AED pad at least 1 full inch away from the metal device to prevent the internal battery from physically blocking the life-saving shock. The absolute ultimate goal of this brutal, high-stakes physical violence is successfully achieving what professionals call the return of spontaneous circulation, an incredible biological victory, universally abbreviated as ROSC. A team instantly knows they have achieved this miraculous feat the exact second they feel a strong, palpable pulse suddenly hammering against their fingers, or if the supposedly dead patient suddenly begins violently breathing on their own or moving their limbs. The moment ROSC is officially declared, the team must instantly halt all chest compressions and aggressively transition directly into post-resuscitation care, shifting their entire tactical focus onto keeping this incredibly fragile human being mathematically stable. Evaluation frameworks will rigorously test a responder's ability to execute these critical next steps, which typically demand aggressively securing the biological airway, mechanically supporting their weak ventilations, artificially maintaining their blood pressure, and initiating rapid, high-speed transport directly to the nearest hospital. Pulling off a successful cardiac resuscitation in the real world relies entirely on executing flawless, highly choreographed teamwork and utilizing what modern professionals refer to as the pit crew model. Inside this high-speed operational framework, every single arriving responder is instantly assigned a strictly predefined tactical role, such as the dedicated compressor, the airway manager, or the specialized AED operator, a system designed entirely to crush chaos and ensure seamlessly smooth physical transitions. Because delivering high-quality, bone-crushing compressions is intensely physically exhausting, the team must rigidly rotate the human being doing the pumping exactly every 2 minutes to prevent massive muscle fatigue from destroying the overall quality of the rescue. Advanced testing frameworks frequently evaluate a student's total understanding of these intense team dynamics, highlighting that maintaining seamless, clear communication and adhering to highly structured physical roles are just as vital as the actual medicine when it comes to saving human lives. Understanding the terrifying reality of how a human heart fails is the absolute first step in mastering the complex, high-speed interventions required to restart one in the field. If you are fascinated by these incredible biological mechanics and want to professionally prepare to deploy these aggressive, life-saving protocols yourself, you can utilize the highly realistic practice tests and the specialized offline app included with this course to build your absolute readiness. Exposing yourself to intense, heavily formatted scenarios through active study is the absolute most effective way to lock in these complex physiological rules, ensuring you can confidently recognize and violently attack these time-critical emergencies before the clock runs out. Don't forget to check the description to get your free study guide and additional resources to help you prepare and get ready for the next step of this journey, where we will dive directly into the complex and unpredictable world of severe medical emergencies and advanced toxicology. In the high-stakes world of emergency medicine, the most frequent calls you will face aren't always the dramatic traumas you see in movies. They are the silent, internal battles occurring within the human body. Welcome to the fascinating, fast-paced world of medical emergencies and toxicology, where we master the art of medical detective work, from diagnosing the silent progression of strokes and the chemical chaos of diabetic crises to identifying hidden drug overdoses. Because medical calls make up the vast majority of all emergency responses, sharpening your clinical intuition is the single most important step toward becoming a confident, effective provider. We are about to sharpen those assessment skills, and to lock in these core concepts before moving ahead, I highly recommend using our specialized practice tests, or the offline app, which are designed to challenge your knowledge in a realistic, high-pressure format. One of the most frequent and daunting challenges you will face is the patient presenting with an altered mental status, a condition where the individual is fundamentally not acting like their normal self. This behavior ranges from subtle, confusing lapses in personality to total, unresponsive stillness. And, because the causes are so diverse, professionals rely on the OU TIPS mnemonic to navigate the possibilities. This tool reminds you to consider alcohol, epilepsy, insulin issues, oxygen deprivation, uremia, trauma, infection, psychiatric conditions, and the potential for a stroke. Your role is not to perform an exhaustive, academic diagnosis, but to rapidly gather clues from the patient's environment and history to steer your immediate, life-saving interventions. A stroke, or cerebrovascular accident, is one of the most time-critical neurological emergencies you will ever manage, occurring when vital blood flow to the brain is suddenly severed. These events generally fall into two categories: ischemic, where a blood clot physically plugs a brain vessel, or hemorrhagic, where a weakened vessel ruptures and leaks blood directly into the brain tissue. In both scenarios, the clot is your primary enemy, as brain cells begin to perish rapidly, making your early intervention the most critical factor for the patient's long-term survival. To rapidly identify a stroke in the field, you will utilize the Cincinnati Pre-Hospital Stroke Scale, a tool heavily emphasized on the NREMT exam because of its life-saving precision. This scale focuses on 3 objective indicators: facial droop, where one side of the face remains motionless during a smile; arm drift, where a patient closes their eyes and attempts to hold their arms out straight, and speech patterns, where you listen for slurred or bizarre phrasing when they repeat a simple sentence. If you identify even one of these three abnormalities, you must treat the situation with the highest level of urgency, as there is a very high probability that the patient is actively experiencing a stroke. Another frequent neurological event is the seizure, a sudden, chaotic electrical fire within the brain that completely disrupts the patient's normal function. The most visually striking version is the generalized tonic-clonic seizure, during which the patient loses all consciousness and experiences violent, rhythmic muscle contractions across their entire body. Some individuals experience an aura, a sensory warning, like a flash of light or an odd scent, that alerts them just before the seizure begins. When you arrive to find someone actively seizing, your fundamental duty is to clear the environment of dangerous objects to prevent the patient from causing themselves further physical harm. Once the electrical surge ceases, the patient will naturally drift into the postictal state, a critical recovery window where the brain works to recalibrate. During this time, the patient will likely be deeply unresponsive, slowly waking over 5 to 30 minutes while acting disoriented and physically exhausted. Because the brain just burned a massive amount of energy, the patient may breathe very fast to compensate, and your absolute priority is to protect their airway and provide supplemental oxygen as you suction any excess saliva or vomit. Shifting to the endocrine system, you must understand the management of diabetic emergencies, which are entirely governed by the hormone insulin. Insulin acts as the essential chemical key that unlocks a cell, allowing blood sugar to enter and fuel the body. People with type 1 diabetes produce no insulin, while those with type 2 either produce insufficient amounts or exhibit cells that are resistant to the hormone. Without this precise balance of sugar and insulin, patients can rapidly encounter life-threatening physiological complications that you must be prepared to identify. Hypoglycemia, or critically low blood sugar, is the most common and rapid diabetic emergency you will likely witness. This state often happens when a diabetic patient takes their insulin but misses a meal, causing their blood glucose to plummet dangerously. A hypoglycemic patient will present with an altered mental status, and you will notice their skin is pale, cool, and clammy, symptoms that closely mimic the signs of physical shock. Because the human brain relies entirely on a constant stream of sugar, a rapid drop can cause aggressive outbursts, seizures, or total unconsciousness in just a few minutes. Conversely, hyperglycemia is a state of abnormally high blood sugar that typically develops slowly over days or weeks. When the body is unable to move sugar into the cells, it begins to metabolize fat for energy, creating dangerous waste products known as ketones that lead to diabetic ketoacidosis, or DKA. A classic scenario on the certification exam will describe a patient with sky-high sugar levels, deep and rapid Kussmaul respirations, and a distinct, sweet, fruity odor on their breath, signaling the body is trying to blow off excess acid. To practice identifying these subtle physiological differences under stress, reviewing the detailed scenarios in our practice tests or the offline app can be incredibly beneficial. Your primary treatment for a conscious diabetic with low blood sugar is the administration of oral glucose, a specialized gel packed with pure, fast-acting sugar. However, there is a rigid, mandatory rule you must follow, which is a common testing point. You may only administer this gel if the patient is fully awake, possesses an intact gag reflex, and can swallow effectively on their own. If a patient is unconscious or lacks the ability to swallow, forcing gel into their mouth is a fatal error, as they will likely choke and aspirate the substance into their lungs. Allergic reactions are a frequent emergency, but you must constantly differentiate between a localized, mild reaction and the systemic, life-threatening crisis known as anaphylaxis. A mild reaction might manifest only as a rash, itching, or hives, and rarely requires aggressive medical intervention. Anaphylaxis, however, is a severe total body reaction that simultaneously triggers airway swelling, severe wheezing, and a dangerous drop in blood pressure. To pass the certification exam, you must recognize that signs of shock or airway compromise are the definitive red flags that escalate a minor allergy into a full-blown anaphylactic emergency. The definitive treatment for anaphylaxis is the epinephrine auto-injector, or EpiPen, a powerful tool that reverses the deadly effects of the reaction. Epinephrine works by aggressively constricting the body's blood vessels and forcefully dilating the airway, which effectively restores critical circulation and breathing. You administer this by pushing the device firmly into the lateral thigh and holding it there for several seconds. Always monitor the patient closely afterward, as the medication will dramatically spike their heart rate and cause them to feel jittery or anxious. You will also frequently treat patients with chronic respiratory conditions like asthma and chronic obstructive pulmonary disease, or COPD. Asthma is typically an environmental or allergic response that causes the small airways to spasm and fill with mucus, producing the high-pitched whistling sound we identify as wheezing. COPD is usually the result of long-term damage, often from cigarette smoking, which permanently alters the lungs and makes every breath a struggle. Both groups of patients often require the use of prescribed rescue inhalers, which you can safely assist them with if their breathing becomes severely impaired. Gastrointestinal emergencies often manifest as an acute abdomen, a term for sudden, severe belly pain. Causes vary wildly from appendicitis and gallstones to internal ulcers, but your field management remains consistent regardless of the underlying cause. You will often find these patients instinctively pulling their knees up to their chest to relieve tension on their stomach muscles, a position you should allow them to maintain during transport. Treat these patients with extreme care, provide emotional support, manage the potential for shock, and never offer them anything to eat or drink. Toxicology is the study of poisons and how they damage human systems, covering everything from accidental overdoses to industrial chemical exposures. A poison typically enters the body through one of four routes: ingestion, inhalation, injection, or direct absorption through the skin. Your scene size-up is the most critical phase here, as you must identify needles, pill bottles, or chemical containers before you approach the patient safely. Understanding the specific route of entry will dictate your decontamination strategy and the specific life-saving treatments you provide. Opioid overdoses are an incredibly common emergency today, involving substances like heroin, fentanyl, and powerful prescription painkillers. The classic presentation is a deeply unconscious patient with pinpoint pupils and severe respiratory depression, sometimes breathing only once or twice a minute. Your priority is to manage their airway with a bag valve mask and administer naloxone, or Narcan, which instantly displaces the opioids from the brain's receptors. The exam will remind you that Narcan is specific to opioids and is completely ineffective against other substances like cocaine or alcohol. Unlike opioids, which suppress the central nervous system, sympathomimetics are stimulants that kick the body into overdrive. Drugs in this category include cocaine, methamphetamine, and ecstasy, all of which cause rapid heart rates, high blood pressure, dilated pupils, and often paranoid or aggressive behavior. Your primary goal is to prioritize your own safety, manage the patient's airway, and ensure rapid transport, as these individuals are at a severe, heightened risk for seizures or sudden cardiac arrest. Carbon monoxide poisoning is a silent killer that requires extreme vigilance, especially in colder months. This colorless, odorless gas is produced by incomplete combustion in things like faulty heaters, running cars, or house fires. It binds to red blood cells much more effectively than oxygen, essentially suffocating the patient from the inside out while their skin remains a normal color. A dangerous exam trap is that standard pulse oximeters will often read 100% saturation, giving you a false sense of security. You must always provide high-flow oxygen, regardless of what the machine says. When facing complex toxicology cases, you are not expected to be a walking encyclopedia of every poison on Earth. You have the powerful resource of the Poison Control Center, or your online medical direction for expert guidance. These experts can analyze specific pill combinations, household chemicals, or industrial substances to tell you exactly how to intervene. Knowing exactly when to request this expert help is a hallmark of a professional EMT, and exam scenarios will often frame this as the safest and most appropriate action. Congratulations on finishing this comprehensive section on medical emergencies and toxicology. I strongly encourage you to complete the practice tests for this module, or use the offline app to review the material, as tackling these realistic, high-pressure scenarios is the absolute best way to sharpen your retention and exam readiness. You will find that these practice tools are excellent companions to your study, ensuring you can confidently identify and treat a wide variety of complex conditions. Keep embracing this active learning strategy, as it builds the critical thinking you need to succeed, and prepare for our next phase, where we will conquer the high-speed world of trauma and shock management. In the chaos of an emergency scene, the difference between life and a fatal outcome often comes down to how fast a responder can process the physics of a catastrophe. Welcome to the high-intensity world of trauma and shock management, where we master the mechanical laws of injury, the precision of hemorrhage control, and the aggressive protocols required to reverse biological collapse. This exploration is vital because trauma calls move at a frantic pace, demanding rapid, decisive action to rescue patients who are effectively bleeding out in real time. Mastering these intense skills makes you a vital tactical asset on any rescue scene, and to lock in these high-stress protocols before moving forward, utilizing our specialized practice tests or the offline app serves as an excellent way to reinforce your real-time decision-making abilities. To treat a trauma patient with true mastery, you must first understand the kinematics of trauma, which is the study of how kinetic energy transfers into human tissues during a physical collision. By meticulously examining the mechanism of injury, such as the velocity of a vehicle crash or the exact height of a fall, you can accurately predict the types of invisible internal injuries a patient might have sustained. The NREMT exam will constantly force you to use these environmental clues, expecting you to maintain a high index of suspicion for severe, life-threatening injuries, even when the patient appears deceptively calm on the outside. Trauma is fundamentally categorized into two types: blunt and penetrating. Blunt trauma occurs when a massive force strikes the body without rupturing the skin, such as a steering wheel impacting a chest, which frequently causes catastrophic internal hemorrhaging. Penetrating trauma involves an object, like a knife or a bullet, piercing the skin, creating a direct, high-risk pathway for severe external blood loss and secondary infection. Recognizing the difference between these forces dictates whether your primary focus must be on finding hidden internal damage or aggressively managing obvious, life-threatening external wounds. Identifying the specific nature of external bleeding is your absolute first priority, with arterial bleeding standing out as the most lethal. Arterial blood is bright red and forcefully spurts in time with the patient's own heartbeat, meaning a victim can bleed to death in mere minutes if you do not intervene instantly. Venous bleeding appears dark red and flows in a steady, constant stream, while capillary bleeding is a minor, slow ooze typically found in simple surface scrapes. Professional exams prioritize bleeding control over every other intervention, requiring you to address massive arterial hemorrhage before you even consider opening a patient's airway. The very first maneuver for significant bleeding is the application of forceful, direct pressure straight down onto the wound using a sterile dressing. You must use your gloved hand to push firmly against the injury, maintaining that tension without lifting your hand to check the wound, as peeking destroys the fragile blood clots currently attempting to form. If blood soaks completely through your first layer of gauze, you must never remove it, but instead place a second dressing directly on top and press even harder. This fundamental skill is heavily tested because it remains the most common and effective way to halt hemorrhage in the field. If direct manual pressure fails to stop severe bleeding on a limb, you must immediately deploy a commercial tourniquet. A tourniquet is placed high and tight on the extremity, generally 2 to 3 inches above the bleeding site, but never directly over a joint. You must tighten the device until the bright red spurting completely stops, and you can no longer palpate a pulse below the site of the injury. A classic testing tip is to clearly record the exact time of application on the tourniquet or the patient's forehead, as the hospital team requires this data to calculate how long the limb has been deprived of circulation. Beyond massive hemorrhage, you will manage a wide variety of soft tissue injuries, including abrasions, lacerations, avulsions, and complete amputations. An avulsion occurs when a flap of skin is torn loose, requiring you to gently fold that tissue back into its natural position before dressing the area. For complete amputations, you must wrap the severed part in a sterile dressing, place it inside a watertight plastic bag, and keep it cool by resting that bag inside a secondary container filled with ice water. You must never place the body part directly against the ice, as this will freeze the tissue and destroy any possibility of surgical reattachment. Burns are a distinct type of tissue injury defined by their depth and the percentage of the body they cover. Superficial burns affect only the top skin layer, while partial thickness burns trigger intense pain and blistering, and full thickness burns destroy all skin layers, often leaving the area charred, leathery, and entirely without sensation. To calculate the scope of the injury, you utilize the rule of nines, which assigns specific percentages to body parts, such as 9% for the entire head and 18% for the front of the torso. You treat these by stopping the burning process, removing smoldering clothing, and covering the area with dry, sterile dressings to prevent infection and heat loss. To test your precision with these complex mathematical calculations, reviewing scenarios on our practice tests or the offline app is an excellent way to see how they appear on the actual exam. Musculoskeletal trauma involves fractures, dislocations, sprains, and strains, all involving the bones, joints, and muscles. A fracture is a broken bone that can be closed with the skin intact or open, where the bone pierces through the skin, introducing a massive risk for infection. A dislocation happens when a joint is forced out of its normal anatomical socket, often locking the limb in an awkward, painful angle. While these injuries are visually shocking and painful, the exam will remind you that they are rarely life-threatening unless they involve massive blood loss from major structures like the pelvis or the femur. The core treatment for musculoskeletal injuries is splinting, which immobilizes the bone to prevent further damage to underlying nerves and blood vessels during transport. The golden rule of splinting dictates that you must always immobilize the joint directly above and the joint directly below the injury site. Before and after applying any splint, you must check for PMS, pulse, motor function, and sensation, in the extremity. If a patient has a strong pulse before splinting but loses it after you secure the device, the splint is tied too tightly and must be loosened immediately. A highly tested, specialized piece of equipment is the traction splint, designed exclusively for isolated mid-shaft femur fractures. The femur is the body's largest bone, and when it breaks, the powerful thigh muscles naturally spasm and pull the broken ends past each other, causing excruciating pain and internal hemorrhage. A traction splint uses mechanical pulleys to gently pull the leg back to its normal length, relieving the spasm and reducing internal bleeding. You must remember that a traction splint is strictly contraindicated if the patient has additional injuries to the hip, knee, or ankle on that same limb. Head injuries are terrifying because the brain is trapped inside a rigid skull with absolutely zero room to expand if it begins to swell or bleed. A concussion is a mild traumatic brain injury that results in temporary confusion or memory loss, but epidural and subdural hematomas involve active bleeding inside the skull. This internal bleeding builds pressure that eventually squishes the brain tissue downward toward the spinal cord. Recognizing the signs of increasing intracranial pressure is vital, as it often requires you to slightly hyperventilate the patient and rush them to a specialized trauma center. To identify intracranial pressure on the NREMT exam, you must memorize the vital sign pattern known as Cushing triad. While most shock patients have a fast heart rate and low blood pressure, a patient with a severe head injury presents with the exact opposite. Cushing triad consists of a very high blood pressure, a dangerously slow heart rate, and an irregular breathing pattern. If a scenario describes a patient who was struck in the head and now presents with a blood pressure of 200/100 and a heart rate of 40, You must identify this as a critical brain injury. Suspected spinal injuries require meticulous care, as any careless movement could sever the spinal cord and cause permanent paralysis. If the mechanism of injury suggests a spinal fracture, your absolute first action must be holding manual, inline stabilization of the head and neck. You will then apply a rigid cervical collar to maintain this neutral position, ensuring it fits perfectly without obstructing the airway. You must maintain your manual grip on the head until the patient is completely secured to a long backboard or firmly strapped onto your stretcher. Chest trauma can drastically compromise the body's ability to breathe, particularly in the case of a flail chest, where 3 or more adjacent ribs are broken in multiple places. This creates a floating segment of the rib cage that moves in the opposite direction of the chest during breathing, a dangerous condition known as paradoxical motion. This prevents the patient from pulling in a normal breath and bruises the underlying lung tissue. Your primary treatment involves supporting the patient's breathing with a bag valve mask, as the positive pressure helps push the flail segment outward and expands the lungs. Another critical chest injury is a sucking chest wound, where a puncture to the chest wall allows air to rush into the chest cavity every time the patient inhales. This trapped air begins to collapse the lung, leading to a deadly condition called a tension pneumothorax. You must immediately cover the hole with an occlusive dressing, a plastic or foil bandage that blocks air from entering but allows trapped air to escape out the sides. Exam questions will constantly test your reflex to slap a gloved hand over this wound the second you see it, even before you reach for a formal dressing. Abdominal trauma can result in a gruesome injury called an evisceration, where a large laceration allows the internal organs, typically the intestines, to spill out of the body. You must never attempt to push the organs back into the abdominal cavity, as this will cause massive infection and tissue damage. Instead, you cover the exposed organs with a large, sterile dressing soaked in sterile saline, and then cover that moist layer with an occlusive layer to trap body heat. The NREMT exam frequently tests this exact bandaging sequence to ensure you know how to protect these vital organs from drying out. All severe trauma eventually leads to shock, medically known as hypoperfusion, where the organs are not receiving enough oxygenated blood to survive. Shock progresses through stages, beginning with compensated shock, where the body panics to save itself by increasing the heart rate and constricting blood vessels. If bleeding continues, the patient enters decompensated shock, marked by a sudden, dangerous drop in blood pressure, indicating that the body has completely run out of energy and the compensatory mechanisms are failing. You must catch shock in the compensated stage, because once blood pressure drops, the patient is incredibly close to death. There are several types of shock, but hypovolemic shock is the most common in trauma, caused by massive blood loss. Cardiogenic shock occurs when the heart is damaged and cannot pump, while neurogenic shock happens when a spinal cord injury paralyzes the blood vessels, causing them to suddenly dilate. Regardless of the specific type of shock, the field treatment remains the same for an EMT. Aggressively manage the airway, apply high-flow oxygen, keep the patient warm with thermal blankets, and initiate immediate, rapid transport to the hospital. Congratulations on completing this intense and comprehensive section on trauma and shock management. I encourage you to complete the attached practice test for this module, as visualizing these high-stress scenarios through practice questions is the best way to improve your retention and exam readiness. You will find the practice test included with this lesson, or you can access our offline app anytime to help you confidently master bleeding control, splinting, and shock recognition. Embracing these interactive resources ensures an active learning approach, making you a much stronger provider on the streets, and you are now ready to naturally transition to our final section, where we will explore the unique challenges of special populations and obstetrics. Have you ever wondered why emergency medicine isn't a one-size-fits-all science? When a 911 call involves a pregnant woman, a newborn baby, a young child, or an elderly patient, the standard medical playbook often has to be thrown completely out the window. That is because these incredibly unique patients are undergoing massive physiological changes or limitations that make standard adult protocols not just ineffective, but potentially dangerous. Exploring these hidden vulnerabilities is fascinating, and mastering how to adapt to them is exactly what emergency professionals do through frameworks like the NREMT, National Registry of Emergency Medical Technicians, certification. In this documentary-style deep dive, we are going to explore how the human body fundamentally changes across different stages of life, and look at how medics prepare for our most vulnerable patients. A journey you can actually follow yourself by testing your own instincts against realistic scenarios. We start at the very beginning of life, looking at the incredible, often invisible transformations of a pregnant woman's body. During pregnancy, a mother's blood volume expands by an astonishing 50% to support the growing life inside her, and her heart rate naturally speeds up to pump all that extra fluid around. However, because her body doesn't produce red blood cells at the exact same accelerated rate, she often becomes anemic and deeply fatigued. Understanding these baseline biological shifts is fascinating, and for emergency responders, it is a critical piece of the puzzle. It explains why a pregnant trauma victim might hide the classic, terrifying signs of severe blood loss and shock until she has lost a massive amount of blood. As the pregnancy reaches its final stages, the sheer physical weight of the baby introduces a bizarre and dangerous mechanical problem. If a woman in her third trimester lies completely flat on her back, the heavy uterus and amniotic fluid actually crush the inferior vena cava, which is the massive vein responsible for returning blood back to her heart. This internal roadblock causes her blood pressure to crash instantly, leaving her dizzy, nauseous, and on the brink of passing out. To solve this terrifying issue, medics are trained in a simple but life-saving maneuver. They always transport these patients tilted slightly onto their left side, physically shifting the weight off that vein to immediately restore normal blood flow. There are also hidden, internal storms that can brew during pregnancy, the most alarming being a condition known as preeclampsia. This dangerous complication acts like a pressure cooker, causing high blood pressure, sudden swelling in the hands and feet, and blinding headaches. If the warning signs are missed, the brain's electrical system can overload, triggering eclampsia, which violently manifests as life-threatening maternal seizures. When a pregnant woman suddenly begins seizing, the chaotic scene demands a calm, standard rescue protocol. First responders must fiercely protect her airway, blast high-flow oxygen, and cushion her head from impacting the floor, all while rushing her to a specialized hospital, because the only definitive cure for this terrifying condition is the delivery of the baby. Another incredibly urgent situation is severe bleeding during pregnancy, usually stemming from two distinct internal placental failures. Sometimes, the placenta develops completely over the cervix, an anomaly called placenta previa that results in painless, bright red bleeding as the body attempts to prepare for birth. Far more violent is an abruptio placenta, a traumatic nightmare where the placenta rips away from the uterine wall entirely too early, triggering agonizing, tearing abdominal pain and dark, hidden bleeding. Whether examining the underlying biology out of curiosity or studying for a professional exam, the overarching rule remains identical. Massive internal bleeding during pregnancy demands extreme urgency, rapid transport, max oxygen, and aggressive shock management, regardless of the exact diagnosis. Of course, sometimes nature simply refuses to wait for the hospital, forcing emergency responders to orchestrate a sudden field delivery on a living room floor or in the back of an ambulance. The immediate priority becomes transforming a chaotic environment into a clean, sterile landing zone, positioning the mother on her back with her knees bent and placing sterile towels around her. As the baby's head finally begins to emerge, an intense moment known as crowning, the medic's job is surprisingly restrained, gently placing gloved hands on the tiny skull to prevent a dangerously explosive birth. The secret to a successful emergency delivery is not pulling the baby into the world, but rather supporting the head and allowing the mother's immense, natural contractions to safely push the baby into your hands. Nature's process isn't always flawless, and one of the most frightening complications occurs when the umbilical cord ends up wrapped like a tight snare around the baby's neck. In the precious seconds immediately after the head emerges, a medic must swiftly sweep a finger along the back of the infant's neck, to feel for this hidden danger before the shoulders follow. If they discover this nuchal cord, the first instinct is to gently maneuver it over the infant's head to release the chokehold. But if the cord is pulled too tight and simply won't budge, emergency responders have to make a split-second decision to clamp it in two places and carefully snip it, preventing the baby from being strangled as the rest of the body is pushed out. The moment the child fully enters the world, the focus instantly shifts to neonatal survival, where the greatest invisible enemy is simply the cold air of the room. The absolute first priority is grabbing clean towels and vigorously drying the slippery newborn. This intense friction is a brilliant, dual-purpose medical tactic. It rapidly halts the life-threatening evaporation of body heat, while simultaneously providing the jarring physical stimulation needed to shock the baby into taking its first crying breath. Once dry, those wet towels are immediately discarded and replaced with a warm, dry blanket, and the baby's head is carefully covered, as infants can lose a catastrophic amount of heat from their bare scalps, a mistake that rapidly drains their fragile energy and oxygen reserves. To quickly judge how well this brand new human is handling the shock of the outside world, medical professionals use a rapid assessment tool known as the APGAR score at exactly 1 minute and 5 minutes of life. This simple but brilliant system grades the infant's appearance, pulse, grimace, activity, and respiration on a scale from 0 to 2. A thriving, healthy baby will boast pink skin, a racing heart rate well over 100, strong kicking limbs, a furious cry, and deep, greedy breaths of air. Mastering this visual checklist is a major milestone for anyone training in the NREMT framework, as medical scenarios constantly force students to calculate these precise numbers under pressure to figure out exactly what life-saving step comes next. If that newborn arrives blue, silent, or with a heart rate tragically lagging below 100 beats per minute despite rigorous rubbing, the atmosphere in the room shifts to high-stakes resuscitation. Medics will instantly deploy a tiny, specialized bag valve mask to force gentle puffs of room air into the microscopic lungs at a frantic pace of 40 to 60 breaths every minute. If the heart rate plummets below 60 beats per minute, even with perfect breathing assistance, the situation demands immediate neonatal chest compressions, using a delicate two-thumb technique, wrapping around the tiny chest. The CPR rhythm for a fragile newborn is an incredibly rapid 3 compressions to 1 breath, a ratio that beautifully illustrates how oxygen starvation, rather than sudden cardiac failure, is almost always the true villain in this delicate population. As babies grow into curious children, the medical rulebook shifts again, heavily emphasizing that kids are absolutely not just miniature adults. Their internal wiring runs at a wildly different pace, featuring lightning-fast heartbeats and rapid breathing, coupled with surprisingly low blood pressure, which means medics have to memorize entirely different vital sign charts for infants, toddlers, and older kids. More alarmingly, tiny pediatric lungs hold virtually zero reserve oxygen, meaning a child struggling to breathe will burn through their energy and abruptly stop breathing far faster than an adult ever would. Identifying the incredibly subtle, early warning signs of this exhaustion before a child spirals into full respiratory failure is one of the most critical skills in emergency medicine. To catch those subtle clues before touching a terrified child, professionals rely on a genius observational method called the Pediatric Assessment Triangle. This rapid-fire visual scan focuses entirely on 3 simple pillars: the child's overall appearance, how hard they are working to breathe, and the color of their skin. Just by standing in the doorway, a trained observer can instantly spot if a toddler is lethargic and floppy, if their neck muscles are straining violently with every gasp, or if their skin has turned an unnatural, ashen pale. It is a legendary diagnostic trick that allows responders to know within seconds whether they have time to gently coax a smile out of the patient or if they need to grab the child and run for the ambulance. When children do suffer from respiratory distress, 2 common but incredibly different invisible enemies often cause the chaos: croup and epiglottitis. Croup is an aggressive viral bug that inflames the upper windpipe, causing a bizarre, high-pitched barking cough that echoes through a house like a seal. Epiglottitis, on the other hand, is a terrifying bacterial monster that massively swells the tissue just above the vocal cords, leaving a highly contagious child feverish, drooling, and gasping for air. If a medic even suspects this bacterial trap, they must tread incredibly lightly, offering oxygen from a distance while keeping the child absolutely perfectly calm, because simply peering into their mouth with a flashlight can cause the entire airway to violently spasm and lock shut. The physiological differences of children become even more deceptive when they experience physical trauma, mostly because their young skeletons are remarkably rubbery and resilient. While it is rare for their flexible bones to actually snap, this pliability hides a dark secret. The brutal kinetic energy of a car crash doesn't bounce off their ribs. It travels right through them, tearing into the soft organs underneath without leaving a single broken bone as a clue. Because a child's incredibly strong circulatory system can mask severe internal bleeding and maintain normal blood pressure for surprisingly long periods, a sudden drop in pressure isn't an early warning. It is often a fatal cliff edge. Dealing with pediatric trauma requires an intense, paranoid level of suspicion, forcing medics to rush kids to trauma centers even when they look perfectly fine initially. Moving to the opposite end of the human timeline, the elderly population presents an entirely different maze of biological tricks and chronic complications. As the human body ages, the brain literally shrinks in size, leaving dangerous empty pockets of space inside the hard skull, making older adults terribly vulnerable to tearing fragile blood vessels and slowly bleeding into their brains after seemingly harmless, minor falls. Simultaneously, their aging nervous system stops sending reliable alarm bells, meaning a grandparent might be suffering a massive, crushing heart attack or a ruptured internal organ, yet only complain of mild weakness. Emergency professionals are essentially forced to become highly suspicious medical detectives, treating every vague, easily dismissed complaint from an elderly person as a potential hidden catastrophe. Further complicating this elder puzzle is a modern chemical reality known as polypharmacy, where patients swallow a daily cocktail of multiple, overlapping prescription drugs. When these different chemical agents collide inside an aging liver or kidney, they can spark bizarre and dangerous chain reactions that flawlessly mimic the symptoms of a massive stroke, severe dementia, or sudden heart failure. To untangle this pharmaceutical web, first responders must literally scoop up every pill bottle in the house, throwing them into a bag, to give the emergency room doctors a fighting chance at deciphering the chemical chaos. An unexplained, sudden plunge into confusion or altered reality in an elderly patient should always trigger alarm bells for an accidental overdose or a toxic prescription collision. Beyond the physical ailments, unlocking the mystery of a geriatric emergency heavily relies on mastering the lost art of deeply empathetic, strategic communication, especially when failing eyesight or hearing is involved. To break through the confusion, a rescuer must step into the patient's line of sight, introduce themselves clearly, and speak in a calm, grounded tone without aggressively shouting, so their lips and expressions can be easily read. If the patient's mind is clouded by Alzheimer's or advanced dementia, fighting their fractured reality or snapping in frustration is a disastrous, amateur mistake. The true mark of a medical professional is the ability to gently guide a disoriented mind while quietly pivoting to family members or caregivers to unearth the factual medical history. This heavy reliance on family dynamics is also crucial when responding to the complex world of individuals living with special medical needs, such as those permanently tethered to home ventilators, feeding tubes, or breathing stomas. When a highly specialized piece of medical hardware suddenly malfunctions or gets choked with biological debris, the absolute smartest people in the room are rarely the paramedics. It is usually the exhausted parents or daily caregivers. Recognizing this, the smartest strategy is to instantly drop the ego, listen to the family's intimate knowledge of the machinery, and collaborate with them to safely troubleshoot the equipment. A true test of medical competence is seamlessly stepping into this intricate home care environment, knowing precisely how to suction a clogged artificial airway or manually pump life-saving air through a plastic tube in someone's neck. Finally, Navigating the world of society's most vulnerable populations requires a vigilant, unflinching eye for the darkest reality of emergency response, the silent epidemic of abuse and neglect. The grim puzzle pieces are often hidden in plain sight, revealing themselves through bruises in varying, unnatural stages of healing, physical trauma that violently contradicts the official story, or a controlling caregiver who aggressively speaks over a terrified patient. While an emergency responder is not a police officer and should absolutely never confront a dangerous abuser in the middle of a tense living room, they are bound by immense legal and moral duty as mandatory reporters to document the shadows. This heavy responsibility challenges the core professionalism of the job, demanding that a provider expertly treat the physical wounds while quietly ensuring the truth reaches the hospital staff and protective authorities. Understanding the incredible, hidden ways the human body changes from the moment of birth to the final years of life reveals just how complex and fascinating emergency medicine truly is. If you found yourself captivated by how professionals adapt to these physiological puzzles, diving deeper into the official curriculum of the NREMT is the perfect way to transform that curiosity into real-world capability. You can test your own instincts against the very same high-stakes medical scenarios that professionals face by utilizing specialized mobile apps and targeted practice examinations designed specifically to build ultimate readiness. Understanding how these systems work is only the beginning. If you want to take your knowledge further and prepare professionally, don't forget to check the description to get your free study guide and additional resources to help you prepare.